Okay, we are live. We are starting. Welcome, everybody. Good morning. Thank you for joining us today. My name is Simona Barbu. I'm a policy officer at FANSA working on our health area. And together with my colleague Raquel today, we will be the hosts for the event. Just a few words from my side before I pass it on to Raquel to introduce our excellent speakers. I would like to remind you all that you are joining the second webinar of our webinar series dedicated to health inequalities and homelessness. And today the topic is going to be the intersection between tuberculosis and homelessness. And we are very grateful to have speakers who have experience from both the academic and medical level, as well as from the ground, from the practical level. So we are looking forward to their presentations, and please do share with us your questions, and also feel free to write in the chat where you are joining us from and what are your experiences with working on homelessness in health in general or tuberculosis specifically. Last words about technicalities. So as you see, we are in a meeting webinar today. That means that we can see and hear each other. So please remain muted as the presentations take place. And also, if we are recording the webinar to make it available for people who have registered but cannot join today in the end. So if you do not wish to appear on the recording, you are welcome to keep your camera off. That being said, we do encourage you to be interactive. So at the end, we will have some time for discussion and questions. So if you want to take the floor, feel free to raise your hand and we can facilitate that for you. So yeah, that's it from me with this short intro. I will pass it on to Raquel, who will moderate the next section. Thank you.
Hello, everyone, and thank you so much for joining us today. We are excited to have you here, and I hope this webinar will provide us a meaningful discussion on the intersection between homelessness and tuberculosis. Today, we will be exploring what is tuberculosis and how it impacts people experiencing homelessness, focusing on the specific challenges faced and highlighting innovative strategies to improve access to care. As for our program, first we will hear from Dr. Raquel Duarte from Portugal. She is a medical doctor specialized in pulmonology, a researcher and a professor. She's also the director of the Public Health Center Gonçalves Ferreira in Porto. I also would like to add that currently she is the president of the European Region Officers International Union Against Tuberculosis and Lung Diseases and a member of ECDC. Following her presentation, we will have two more presentations from Fieldwork Organization and Services, aiming at identifying and discussing interventions that facilitate treatment adherence and provide successful examples of services that work with TB and homelessness. So now I give the floor to Raquel Duarte for her presentation. You can start whenever you want. Thank you.
Thank you all. I'm not a member of CDC. I'm a consultant. I'm a member of the consultant group on TB. So it's a pleasure to be here and to talk about TB. And TB is a multidimensional disease. So it's very important to look to the person with the disease. I'm going to share my slides. Okay, can you see it, right?
Yes.
Okay. So I'm going to start. Okay. So my talk, I'm going to talk about poverty.
Sorry, Raquel, just to say, if you could go into full mode presentation.
It's not in full mode?
No, not for me at least.
Okay, let me try again. So I'm sharing, right? Now, is it in full mode?
No, you stopped sharing the presentation.
Okay, let's go again. It's okay now?
Still not in presentation mode. Now it is. Yeah, now we can see it. Yes.
So, I'm going to talk about tuberculosis and socioeconomic determinants, and I'm going to approach poverty, the rural and urban disparities, the housing conditions, overcrowding, unemployment, occupational risk, and the nutrition, and talk a little bit about vulnerable populations before concluding. So when you see the distribution of tuberculosis across the world, you can see that only few countries have a high incidence of TB. So there is a distribution that is not homogeneous all over the world. And in reality, there is a concentration of TB in lower and middle income countries. In reality, all 30 countries with a high burden of TB, they have, there's something here, sorry. I wanted to take your pictures from the front of the slide. So all 30 countries that have a high burden of tuberculosis, and this is 87% of all new tuberculosis cases, they are low income and middle income countries. So there is a concentration, there is a relation of tuberculosis and poverty. And we are talking about prevalence and incidence, but we are also talking about mortality, TB lethality. So if you look to the pace of decline in TB lethality, you can see that this pace is slower in low and middle income countries. So when we look to the social economic determinants, we are talking about poverty, social class, education, literacy, gender, but we are also talking about the way people live, where people work, crowding, ventilation, malnutrition, and all these have impact on health access to diagnostics, to treatment, and will have an impact on prevalence, incidence, mortality. So all these must be addressed when we talk about tuberculosis. So let's start by talking about poverty and tuberculosis risk. And poverty, as you know, is a multi-dimension construct that includes income, unemployment or employment, education or less of education, access to a healthy environment, living conditions with the way people live, where people work, and access to healthcare. And there are several studies that show that TB incidence is higher in low-income countries where socioeconomic inequality persists. So this is not new for us. But what we can see also is that although TB incidence is decreasing a little bit all over the world, you can see that even in high-income countries, it's steady, so it does not decrease so much. And in some low and middle-income countries, it's slightly increasing. So TB is a problem, and very clear problem in low-income countries, but it's still a problem even in high-income countries. And there are also some studies clearly showing that inequality, income inequality, have an impact on TB prevalence, incidence. So there is this study in Denmark when we can see that low-income earners have higher risk of TB, but also several studies in Brazil, Paraguay, Argentina, that strongly link low income to TB mortality. What we know is that economic development associated with strong public health initiatives can have impact on tuberculosis incidence. So to improve the social conditions, to improve the way people live, people work, the access to healthcare can help to reduce the risk of TB. But social protection reduces tuberculosis. There are several studies showing that if a country increases the investment in healthcare and social protection, can have an impact on incidence and mortality, even in low-income populations. And this study is quite interesting, showing that the impact of social protection in tuberculosis incidence and mortality. So there is clearly a need for economic development and social protection to have a real impact on incidence and mortality from tuberculosis. when we look to the relation between socioeconomic factors and tuberculosis, we have a clear idea that low-income countries and high-income countries do not behave in the same way. In low-income countries, we can see that TB is widespread, right? So poverty exacerbates the vulnerability to the disease. But in high-incidence countries, we do not see that this widespread. We can see that TB tends to cluster in low-income and marginalized, more vulnerable populations, vulnerable groups. So we have different pictures in different countries, but in both of them, there is a connection between the socioeconomic factors and tuberculosis. And so there is clearly rural-urban disparity. And to be poor in a rural area is not the same thing as being poor in an urban area. In the rural poverty, we can see that the difficulties are different. There is a limit access to infrastructures, a limit access to basic services. There is a low employment opportunities, and there is some isolation, geographic and social isolation. In the urban poverty, this is different. Usually, these are industrialized cities, and there is what we find is social fragmentation. So we have the very rich and very poor. We have insecure employment. So we have different kinds of poverties in the rural and urban settings. And there are several studies showing that the urbanization without adequate infrastructure is related with increased TB. High incidence population, high incidence settings are connected with a higher incidence of tuberculosis. And we can see here very clearly that there is really a connection of to be a male or female living in an urban or rural setting has an effect on mortality due to tuberculosis. Housing conditions, the way people live, who do we live with? So if we are living in high humidity, poor ventilation, with lack of basic sanitary services, if we are living in overcrowded areas, with lack of sunlight, poor living conditions. So the way people live is connected with TB incidence and prevalence and mortality, the housing conditions. And there are several studies showing this relation. And how overcrowding. Overcrowding is a major contributor to increase the TB prevalence, incidence, and mortality. There are studies showing that households with 3 and 5 people per room are 3 times more likely to have TB due to the increased risk of exposure, lack of ventilation, increased airborne transmission. And then there is also the higher risk of developing active TB. And people that do not have a roof usually live in settings like this, overcrowded. And we can see that inadequate housing is related with overcrowding, instability, lack of house, and all these connected with improper ventilation, lack of sunlight, dampness, all these have an effect on the continuous evolution of tuberculosis from exposure, with the higher risk of exposure, a lower risk of detection because these people have a delay in diagnosis. And having a delay in diagnosis and living in overcrowded conditions, they will increase the transmission. There will be problems with adherence to treatment, increasing risk of developing resistance, increased risk of poor outcome and recurrence and even mortality. So where people live, the conditions of the housing have a huge impact in all evolution of TB, from exposure to active TB. And employment, or the lack of employment. We cannot forget that unemployment is a risk factor for higher incidence, prevalence, and mortality. The lack of education, low-income areas where unemployment and poverty is high, they are connected with higher incidence and mortality from tuberculosis. And there are several studies showing that. And we can see that for this study in Poland showed that unemployed patients were more likely to be single men, smokers, alcoholic abusers. So unemployment is associated with the documented higher risk of dying from tuberculosis. There's also a connection, a relation between tuberculosis and occupational risk. And we can talk, of course, about the mining healthcare professionals that have exposed to TB patients. But in this talk, I will focus on the occupations with low wages, informal employment, poor working conditions, limited healthcare access. All these increase the vulnerability to exposure, vulnerability to delayed diagnosis, more transmission, lack of adherence, and poor outcome of the tuberculosis treatment. So, and the nutrition. This is another important issue. We know, and there are several studies showing that undernutrition is connected, increases susceptibility of the tuberculosis, worsens outcomes, particularly in immunocompromised individuals with HIV, and there's clearly a need to increase the status of nutrition in the population. There's a geographic overlap between incidence and mortality with undernutrition. And of course, that when we talk about socioeconomic determinants, you need to talk about vulnerable populations. I'm sorry, there is underline something. I hope everything is okay. So the vulnerable populations, and when we talk about vulnerable populations, we talk about migrants and ethnic minorities, and they consistently emerge as highly vulnerable groups across the different studies, mostly because of the precarious living conditions, the legal barriers, so they are not documented, and they have limited access to healthcare, so diagnosis is delayed, and sometimes there is also delay to treatment. There is another group of vulnerable populations are the populations living in institutional settings, such as prisons, and they have higher risk for TB. They live in closed environments, poor ventilation, lack of access to healthcare, and the way they live. So with in an overcrowded setting with a poor ventilation conditions, facilitates the transmission of disease. And there is this is a figure that shows the TB notification rate, the proportion of TB in prisons among total tuberculosis cases in a country as Paraguay, where you know the conditions in the prisons are not the ideal, and they are completely overcrowded. But we cannot forget other vulnerable groups, such as the indigenous populations. And indigenous populations in some countries face some degree of isolation and socioeconomic disadvantage. And this can exacerbate their TB burden, particularly due to the delay of diagnosis and the delays to treatment. And the people that experience homelessness, they face all these social economic determinants that I've been talking about from the beginning, and they live in bad condition, and they face significant barriers to access healthcare, and they have a higher risk of TB mortality. And this is a study, this is also published in the United States, and this is from 1993 to 2014, and you can see the homeless people aged more than 15 years old. To conclude my talk, there's clearly a need of associate with about TB. We talk about early diagnosis, understand people at risk, and to be sure that we screen them and we identify them very so they can start treatment, so they can stop disease in their settings, to be sure that they finish treatment so they don't recover from the disease and they are cured. And then we need to understand how to prevent, so screen the persons at risk, screen the contacts, and provide preventive treatment. At this moment, we have good diagnostic tests, we have good drugs, and we even have some tests that can allow us to identify the persons who can benefit more from prevention. But that's not enough. There's quite good evidence that we need also to provide economic development from the country, to promote strong public health initiatives, to promote social improvements, to assure social protection to the families and to the persons with TB, because that will have an impact on incidence and mortality. And again, not only in high-income countries, but also in low-income countries. So when we talk about TB, we must not forget that TB is a social disease. It's a social disease and presents problems that transcend the conventional medical approach. We cannot look at TB from the hospital. We cannot look at TB from only the medical perspective. We need to look at it as a social disease that needs and will have an impact and it has an impact from the social and economic factors. Thank you. And this is my team.
Thank you very much for your presentation. Now I give the floor to Carolina Marques from Ara do Pinhal, from Lisbon, Portugal. She's a psychologist, a team manager, a team coordinator from the Low Outreach Methadone Program, and a supervisor of the technical team of the municipality shelter. And yeah, you can start whenever you want.
Good morning. First of all, thank you for your invitation to be here and show our work. I will ask you first, sorry about my English because it isn't the best, but I will do my best in order for you to understand. If you don't, please ask me that I will try to explain you in another words. So let's share it. I think that's okay. If it's not, please tell me.
It's perfect.
So my name is Carolina. I will not talk about tuberculosis, but I will. So I will talk about our projects and the way that we approach the tuberculosis. And of course, we have people that are homeless, and so it's very important. I will start to say that Ara do Pinhal is a non-profit NGO for social inclusion, which has worked with people who use drugs since 1986. It has started with a therapeutic community for residential long-term. Since then, with an approach based on humanism, and it has developed several projects in the field of addiction, in the scope of prevention, harm reduction, treatment, and rehabilitation, and other vulnerable population, namely people experiencing homelessness. At this point, you're probably wondering if the topic is tuberculosis and homelessness, why am I talking about a neighborhood in Lisbon, Casalventoso? Well, the slide says, it has begun in the late 80s, 90s, and we had an epidemic with people who use drugs in an open sky scene. So we had more or less 6,000 of people every day to buy and use mostly heroin. There were people living in a poor health condition, and they were sharing material to use. So, as you can wonder, it was a problem, a health problem that could lead us to a very difficult situation. And I'm talking about Casal Ventoso because it's at that time that we started the model that we do treat tuberculosis. So in 97, the municipality of Lisbon started the reconversion of this neighborhood and started to, and started to ask for help in the health screening and the protocol with the Pneumology Diagnostic Center. I think I said it right. And since then, we do the same model in our projects. But for now, I will talk about that projects. I don't see you. Wait a bit. Just to see if I can see you because it's better for me. Okay, now I'm seeing you. Sorry, one more moment. Okay. So I was talking about our projects. We have an integrated support service drug consumption room, an emergency shelter, as Raquel has said, the transitional flats, rehabilitation flats, therapeutic community, and also the methadone mobile outreach program. In the image, you can see here that they were started. And this data belongs to the year of 2023. So we had 110 people in the treatment, the therapeutic community, 1,777 people in the harm reduction program, 26 in the transitional flats, 38 in the rehabilitation and employment, because we have a project of employment, 333 person in the shelter. And also at this year, 691. I will not talk long about our projects because we have a lot of information, but if you want it, we can send you, or if you want, send me an email, I will answer you. So our clients, they have similar characteristics. They have poor working experience, low education, fragile condition, psychopathology, prison history, and they are aged. 85% men, 50% women. The average age is 45 years. Nowadays, with the migrants, this number, the average age is decreasing, okay? We have by nationalities, Portugal is the where we have more people than India, Nepal, and the rest of Europe. We can say that we have a social and healthcare model that we do in all projects. For us, it's very important that the person comes and talk with the team. And after that, we will favor a case manager that will focus on the patient needs. Also, we will give them medical appointments. They can do screening for HPV, HCV, HIV, tuberculosis, syphilis, and pregnancy tests for women. If they need, they can do methadone or other medications, like tuberculosis medication, in that case. So we can also provide them contraception and vaccines. During the COVID, for instance, we gave them the vaccines for COVID, for who wanted. And we do monitoring health conditions and treatments. As we know, sometimes people wanted to go to the services, but they don't have the vehicle to go, or they feel the prejudice of going to the services. So we have a service car that can help with that, and sometimes the technician can go with the person to the services. So it's our main goal also refer the persons to other services like health centers or hospitals, or for instance social care. We have nowadays a lot of migrants, women, and different types of gender. So I can say that we have a therapeutic community, as I said before. In each stages, it has 55 persons and 7 in their integration departments. Talking about tuberculosis screening and the therapeutic community. They do the screening in the moment before they go. So as they are in a protected environment, they only need to do it when they are entering. We can say that in 2023, we had 110 screenings. Of course, if they have any symptoms, we will refer them or to an hospital, or they can do the screening. Transitional flats. The objectives is create living conditions with dignity for the most excluded, promote personal reorganization, provide individual and group psychosocial supports, in order to contribute to their emotional and relational balance, promote the acquisition of basic relational and social professional skills, enabling access to more structured life projects and its insertion in working life. Sorry, I'm nervous. The transitional flats came from a timeline with the pandemic. So with the pandemic, the municipality of Lisbon started an intervention with 4 shelters, and we understood that there were people that were homelessness experiencing homelessness for the first time, and they only need small help to organize and then move to other projects like working, and then to room or other social systems. But they didn't need to stay at the shelters. They just need a space where they can be safe and work that specific areas. So that's how the transitional flat started. It's a maximum capacity for 13 people. How can we screen? It's same as in the therapeutic community. They do it at the beginning. Since the project began in 2020, 50 people have passed through the project and all have been screened once. The mobile outreach program. We are talking about 1,400 people every day with high-risk behaviors, personal disorganization, physical impairment or disease, psychiatric disease, and psychological vulnerability, and also, of course, social exclusion. We can see the data from 1998 until nowadays, and we can see, for instance, in tuberculosis that we had at that time 14%, and nowadays we have only 1%. We can also see that in 2022 we had more or less 20% of people who were homeless, and unfortunately nowadays we have a higher number. It's near 30%. So our mobile outreach program, we want it to be easy to get there. So we need to be near the places where they are using. We need to give them a prompt response. The procedure of coming needs to be simplified. It's an harm reduction approach. And we have our main concern at the beginning is the abstinence symptoms and craving, and how can we help the people to stop feeling that. We screen for all the diseases that I talked before, and we administer different medications every time the person comes. The methadone is a vehicle, so for us, if they come, they will need to go better than the first time they come. We have a general practice once per week, and it's not mandatory, the abstinence. So we have the mobile unit at the field every day from 8:30 until 1:30 p.m. Two mobile units, one in the west side of the city and one at the east side of the city. 5 spots, a service car, and a support office. So the mobile outreach program is run by case managers and educators, nurses, and also a clinical director. It's a user-centered care, and we provide them the social support, healthcare, and refer them to other drug addiction treatment centers or judicial support. We evaluate and see what's their priorities and what they need, and after that we will try to refer them to the system. How can we screen at the mobile outreach program? As I explained in the first time when we started, so the person will come to the program, and within the first 15 days, that person needs to do an X-ray. How can we do that? Can be by a mobile unit, because the Pneumology Diagnostic Center has a mobile unit that comes to the field. But unfortunately, nowadays, it's not so often. So sometimes we need to get other responses. The person can go to the CDP, in English, PDC, or a member of the team accompanies the person to the service with the service car. It will depend on the organization and individual characteristics of the person or other emergency criteria. Of course, if the person is having several symptoms, the person should go to an hospital, of course. During their stay in the program, the person must be screened every 6 months. What if there is a positive result? The diagnostic center will contact us, give us the results, and articulate with the program to take the person's medication under daily direct observation. So as a person is coming to our program to take the methadone, she will have the medicine also, and it will be supervised by a nurse. During the period when the person is taking the medication, it will be the team's responsibility to ensure that the person attends follow-up appointments and follows through with taking the medication. If for any reason the person is not following their medication, the situation should be reported to CDP. So numbers from 2001 until 2023, 22,887 exams, 374 cases, 96% completed treatment, 3.6 dropped out. So the municipality shelter of Santa Barbara, we'll try to fast this. It includes everyone. No one is left behind. We have capacity for 128 clients. We have direct observation taken, a wet house, and that means that people who's inside the shelter can use alcohol and also other drugs. We have a psychosocial team, general practice weekly, psychiatrist weekly, one nurse, and educators. And when we talk about this inside drug consumption room and wet house, we are talking this because we understood that if these people are in a shelter and they need to use, they will do it or inside the shelter or at the street. And we need to decrease the social noise, and we need them to be fulfilled their needs. and we need them to not use at the rooms, because if they do, they will get expelled. So for us, it's very important to have a place where they can use and where they can be treated as people and in a safer conditions. The screening in the shelter is equal to the mobile outreach program. So the person needs to do the X-ray, and after the referral, if it needed, and each 6 months they need to do it again. The screening in 2021 was 37 people, 2022 92, 2023 133, 2024 39 sorry. In all these years, we only have 2 positive cases with the treatment successfully completed. It is very important to say that these numbers are influenced by the times that we have the mobile unit at the field. If we have it more, we will have more screenings, of course. We also have the zero consumption room that is near that neighbor that I talked at the beginning, Casal Ventoso, and some data. So we will have in a regular day 300 people, 300 entries, but only 170 people different. We will try to have a service that provides different types of services with a psychosocial support office, and also to refer them to the other structures at the community. The main goal is to promote dignity, promote health, education, and safer drug use, enable linkage to care and treatments, reduce public health risks, work the personal accountability and inclusion, and promote urban hygiene and reduce social noise. How can we do it in the DCR? The screening is aimed at the DCR users who are using the space on the day that the screening takes place, or those who, for some reason or medical criteria, have an indication to do so. The screening can be carried out in various ways as the other ones. It's with the mobile CDP units, or the person goes on her own, or a member of the team can accompany the person and with our service card. Numbers: 28 screenings, 1 tuberculosis, and of that one, the man dropped the treatment. It was only 28 screenings because we had a few times with the mobile units at the DCR. So our model has some weakness, and as we know, we have a lot of difficulties in screening and treatments. We can say that the mobile screening unit is constantly out of order and only comes to the field a few times for the number of people we follow. We can talk about comorbidities, and it's harder to get people to treatment if they have health mental conditions that will put some difficulties in during the process. Specificities of the treatment, so they always say that it's too long. So as it's too long, they want to abandon. As soon as they feel better, they want to stop taking the medication. The organization of the person, and even taking the MOP becomes the mobile outreach program, the methadone becomes irregular. Taking of medication also, because if they don't go to the mobile unit, they won't take the medication. That leads us to multi-resistant tuberculosis, and it's also very difficult if they have it to do all the processes of taking them to the appointments and stay taking the medicine. Difficulty adhering to appointments, articulation with the health center, because in Portugal nowadays The TB medication is at the health centers, and we need to take it from there. And sometimes it starts disarticulation. Education for non-transmission, because we know that that's not their priority. Most of the time it's ours. So we need to talk with them about these safety measures for the rest of the community. So as I was saying, people's priority may not be to look after their health. The turnover of people and abandonment of projects, and the migrants, because we have a lot of migrants now, and they live in poor sanitary condition, they have poor communication, and overcrowding housing that could be a risk factor. It's not passing. Okay. So this is an example of our communication. At the right, you can see it's in Portuguese, sorry, but it's a game that we do with our clients, that it's myths and facts, where we talk with them and show the cards, and they say that if that sentence is right or wrong, and then we explain. That's part of our intervention with them. Take-home messages: to help people in a vulnerable condition, we have to be in the right place. The right place is where people are. As you can see, we have a higher amount of screenings if we have the instruments on the field. If we don't have it, we will have more difficulties. Only by building a relationship with the clients can he or she have the will to undertake screening and treatment. Practitioners' resilience is fundamental, and respect for times, beliefs, and priorities. Thank you, and sorry about my nervous.
Thank you, Carolina, for your presentation. Now we will move on to our last presentation. I will give the floor to Professor Alstory, who is the founder and the clinical lead of a Find and Treat service. He is also a researcher and a professor. I give the floor to you, and you can start whenever you want. Thank you.
Sorry about that. How long have we got? Sorry, because I'm timetabled to be out of here in 9 minutes. So I'm not sure there's time for mine. Should we just do a Q&A?
No, I think you can take the time you had prepared, Al. It's fine. And then
Okay, because I have to be somewhere else at 11 UK time. So, do you want me to just? I'm probably best to just answer questions rather than trying to do a 50-minute talk in 5. What do you think?
Yeah, sorry about that. But I don't know if there are any questions at this point. If there are, people are welcome to do so. But if you still have like main ideas that you would like to highlight from your work, that would be helpful.
Okay, I'll just have to go very fast. Sorry in advance. Can you see that?
Yes.
Excellent. So I'm Al Story, and I run a service called Find and Treat, and we've been screening in London for over 20 years, and we screen over 10,000 people a year for TB and other things. Now I won't bother with that. So I mean, the main points are, we've moved away from the idea of a service that just targets people experiencing homelessness, because the whole agenda is just so intersectoral. There's a massive crossover, as you've seen from the other presentations, between homelessness, imprisonment, migration, survival, sex work, and drug use. But these populations have the same sort of overlapping risk factors. And I think the take-home message is that the one-size-fits-all service model, which is the usual approach for TB, just doesn't doesn't work, and these groups are systematically failed by services. I mean, the principles of inclusion health, I won't go and share the slides with you, but I mean, the fundamental priority is to reach people early. If we sit in our buildings waiting for people to come to us, then that's too late. We'll see very, very poor clinical outcomes and very, very long chains of transmission. And so our entire model is outreach based. It's all based on building relationships. We use people with lived experience as the front and center of our service, and they're the key, the magic ingredient to develop trust. And we've also devolved the use of most of our diagnostics to non-clinical professionals. I just carry the governance, and we stick with people. And I think the most important thing, as has been mentioned by others, our job is not to kill the pathogen. Our job is to achieve a biosocial cure by addressing the factors that put people at risk in the first place. And for us, the best treatment outcome is in fact a job. Won't bore you with that. So the service is principally at the front end is active case finding. London's pretty much a lens on the world. We see people from all over the world. We've seen 175 different countries on by the outreach crew since 2022. We screen between 10 and 15,000 people a year, using various different approaches, bikes, vans, etc., and street packs. But the whole idea is to create that integrated one-stop shop experience where we're using point-of-care technologies to accelerate the diagnosis and then ideally achieve a same-day treatment initiation. TB is not complicated. The vast majority of cases globally never see a doctor. So we're quite heavy on technology. We've been taking mobile radiology to the streets for many years, and we've done an enormous amount of work to evaluate computer-aided diagnostics. So we're now using lay operators to image, and the AI engine, the CAD, is outperforming people. And we also use what is now the first-line test internationally, the expert test, to confirm diagnosis real time. Won't bore you with that. But I must stress that the service is peer-led. They are front, left, and center of the service. And the technology has basically moved on. It's mind-blowing. My screening journey for TB has gone from 11.5 tons to 3.5 kilos. It's quite mind-blowing. But without the role of the peer, the service wouldn't work. We see people's lived experience as a genuine qualification. And we've extended this role to what we call a peer practitioner role, which is now an accredited training role. And we try and find that magic combination between lived and learned experience to enable the service to reach people. Won't bore you with that. Finding a case of TB is not that difficult in London, but getting people through treatment is a massive challenge. There's a lot of literature around adherence, but I mean, it fundamentally, in my mind, boils down to two issues. There's people who can't take their treatment, and there's people who won't take their treatment. Let's just address can't, because there shouldn't be anybody on the planet who can't take TB treatment. I'll just share with you a couple of the interventions that we've used to try and support people. We pioneered the use of video observed treatment. We give people smartphones, they get a free data deal. A lot of them describe it as having a nurse in your pocket, and it works for people who are extremely precarious and socially vulnerable, and the outcomes are far superior than any other form of direct observation. If that doesn't work, we provide residential respite where people go for the full duration of their TB treatment, and they are 3 times more likely to complete treatment in that environment than if they were left in the community. But fundamentally for us, we're using infectious diseases as a Trojan horse. It's an excuse to get paid to get out and meet more interesting people. And the reality is, on the streets, we're looking at people whose health circumstances is really characterized by very early on non-communicable diseases, frailty, lots of undiagnosed conditions, and a hugely elevated risk of premature death, an enormous burden of unmanaged, undiagnosed mental health problems in the population, and huge issues in terms of safeguarding, safety, dignity, etc. A massive explosion in synthetic opioids is a huge challenge for us at the moment. We're doing a lot of testing, but we're nowhere near the progressive harm reduction agenda of the last talk in terms of what Portugal have pioneered. But fundamentally, we are a trauma-informed service. We work with people who aren't homeless because they lost their key. We work with people who are experiencing deep social exclusion due to stigma, prejudice, racism, abuse, etc. And many of them have had a very, very adverse childhood experience. They were born into poverty and they never escaped. So in a nutshell, peer-led, integrated service, providing a range of options, very research focused, have contributed to multiple guidelines nationally and internationally, and really trying to pioneer the use of technology to accelerate diagnosis and improve treatment outcomes. For us, it's fundamentally a last person first model. This is a concept I developed around the idea of people talking about elimination. Elimination is a great idea, provided you can promote equity rather than amplify inequity. Currently, our approach to elimination is really a service model that's designed for people at the front of the queue. That's not going to work. That's just going to amplify the current huge disparities in terms of treatment survival rates that we're currently seeing. What we need to design is a service for people who aren't in the queue, who don't know where the queue is, and that's a peer-led outreach service. Thank you very much.
Thank you so much, El, for highlighting all these important issues, and it's always great to hear from your work. Apologies again for the reduction of time. If you could stay with us, it would be great. If not, we will make sure to share the PowerPoint with the participants, and whatever questions will arise, maybe we will forward them to you. Thank you all for the presentations. It's been really insightful to hear from the different type of work that you do. So at this point, we are opening the floor for any questions from participants or interventions. Yes, Al, please.
Sorry, I've got to run, but thank you for the invitation, and very nice to see everybody. Bye-bye.
Thank you so much. Have a nice day. So yeah, well, people are, yes, somebody, Natalia Martinez says she has a question to Raquel. Let's see how we can find you and give you the floor, perhaps. Do you want to intervene, Natalia? If so, you can speak directly.
Hi. Yeah, thank you. It's rather probably a request for clarification. I mean, Raquel mentioned that there is proof that social protection reduces TB, and I just wanted to ask her to elaborate a little bit on the notion of social protection, basically what she meant when she said social protection, as this notion is can be understood in various ways. So I'm just very curious. Thank you.
Yes, definitely. The social it's not a proof. What I showed you is the model. Okay, and the model showed you what happened to incidence and mortality from tuberculosis if with or without social protection. And social protection is like you have a huge box, and a huge box can put there a lot of things. What there is, and there are several studies that show that countries, when you talk about elimination, you talk about diagnosis, treatment, prevention, and so on and so on. But what you can see, and there are studies that show that countries that invested in the economic development and the social protection of the families and patients with TB, meaning that they do not lose the money, they do not lose, so they receive some money for when during the time they are not working. So they have some, this is social protection. So they will not lose the money. They can still have access to food. They can still have access to the house, either the patient and the families. So the countries that had this kind of protection of the patient and the families had a better result in terms of the decrease of incidence and mortality. So this is shown when you look to the elimination strategy and the results in different countries. You can see that. So the countries that do have this kind of actions have better results. even in low-income countries. So even in low-income countries, when the countries that do have some preoccupation with this, they have good results. And you can see in the model, so we have the incidence and mortality, and you can see in the model if there is some social protection, there is an improvement with either in incidence and mortality. But this is a box, a huge box, and you can put in the box whatever you want. But even if you put a small thing, such as payment of a salary, even if the person is not working, this has an impact. Of course, that if you are adding more social benefits, the benefit is higher. But the message is that it's not enough to be worried only on diagnostic tests and drugs. It's not enough. We need to look at the person and try to understand what he's losing being sick, or what he's losing, what his family is losing by that person being sick and having to go to clinical appointments, having to go taking medication, having adverse events, and for a long period of time. So what is the cost for the person and the family? And the country, the government must be aware of that if we want to have success. And thank you for the question, Natalia.
Yeah.
Very good question. Thank you.
Thank you to you for the question, Natalia, and Raquel for clarifying that. At this point, maybe if there is no immediate question from the public, I would like to pick up on something that was mentioned in a couple of the presentation in relation to the pandemic period, and the fact that you, Carolina, also mentioned that these transitional apartments appeared as a result of that. And of course, we know that in general in Europe, that period has been quite innovative in terms of innovation, in terms of policies, to protect people. And we did, of course, look closely at what that meant for people experiencing homelessness. We also know that the ECDC has had several reactions on this. So I would like to ask both of you, but also the audience, what are the main lessons learned from that period when you think about TB or other infectious diseases in relation to treatment and prevention among people experiencing homelessness? And do you still see any measures that were taken then back in those years that are ongoing, like the transitional apartments? Is there any other examples that you can think of? Sorry for my long question.
Well, I think that there were a lot of changes, but the services returned to the field. So, of course, by that time, we had a lot of difficulties to get people screened, and the treatments were also challenging way to go with it, because the technicians were also far away from the field, or were not going so often. So it was more difficult to monitorize the treatments and talk with the people. So it was hard. Nowadays, I think we are back on track, and we are doing the screening and the treatments. So I think there were difficult times, but now we don't feel that difficult. Of course, we saw that there were a lot of diseases that we only catch when they were already on a severe condition, and that was because we don't have the screening. But nowadays, I think it's controlled.
Raquel, do you want to reflect on that, maybe in terms of policies that have been rolled out during the pandemic? And
I remember that during the pandemic, we were worried about homelessness people and some vulnerable groups because they were hidden, weren't they? They were hidden. We could not see them. So there was the closure of the schools. There was the closure of some workplaces, and there was some worries about mental health, how people could connect to the work. So there was so many changes the way we lived and worked, but we forgot and we did not see the persons that were in the streets, the vulnerable groups that were not connected with these problems. And at the moment we discussed that, and we involved, I remember that we involved local authorities, NGOs, in order to assure that this person still had some kind of support, a place where they could have access to the toilet and have a bath and have food and have some kind of psychological support and social support and medication and so on. And we had several meetings discussing how this could be done in a safe way for everyone, safe way for the team, safe way for them. So in order to decrease the risk of transmission of disease. So this was something that we discussed at the time and tries to make it work. I think that one thing that comes from that, and as Carolina told us, now everything is coming back to the normal thing. But one thing that comes from the pandemic, and I think that there are some lessons, is that we learned that we cannot forget about everyone. We must think about all the population, and they cannot be forgotten. And all the policies, all the attitudes, all must include all the populations with the different challenges, with the different barriers, because they are completely different. That's something that I think that we learned. We learned the lesson. I think that we did well during the pandemic, because we did worry about them. We did discuss them. We did discuss the strategies. We had several meetings involving everyone, every different stakeholders, in order to identify the best strategy. And I think that's the best lesson, is to never forget to involve everyone. Is there anything still ongoing? I don't think so, because for them it was, they had less contact with the NGOs. So there was at the beginning, at least, there was fear from the infection, fear from transmission. So we needed to ensure that they still were doing their jobs without that fear and safely, of course. But I think that one thing is, the good thing is that now we are back to normal. And of course, that the normal can always be improved, and we must be, I think that we should look to our normal in a critical way, always in a critical way, in a critical good way, because there is always room for improvement. Because I really think that there is room for improvement. And one thing that we should do is to always involve them, the persons that we are working with, in order to identify the best path, because sometimes I think that we look as in a different position. So we know what is best, and we don't know what is best. We don't. So we need to talk with the persons, involve them in the actions, in the policies we propose. We need to discuss with them: are these feasible? Are these good? Can we do better? And I think that's something we learned from the pandemic, because we clearly cannot do something, and cannot, particularly in these vulnerable groups, they have less access to healthcare, particularly when we talk about TB. They have less access to the good housing. So, but they need to talk with us, and we need to discuss with them what is the best strategy. What can we propose? What can we work with them? And that's something, I think that's something we learned, and I hope we can we continue to put in practice.
Thank you so much both for your answers. And Raquel, we couldn't agree more that involving people with lived experience of homelessness and the different diseases that we are looking at is crucial. As Al's story was also presenting earlier, they do tremendous work with peers who are trained and supported and who are people with former experience of homelessness. So maybe if I can continue on that note, I think another question we were reflecting about as well when preparing this webinar was with Raquel about what are people actually saying, what are their experiences when it comes to the take-up of treatment for TB and how do they react to it? Carolina, you had some numbers earlier about how many take treatment and how many drop out. And if I remember well, the dropout number was not so high, actually. Can you share a bit what makes people to stay in the treatment and what is the important aspects for this?
I think the key is the relation within the client and the case manager. Our projects are aimed for help. So for us, it's very important to talk with the person daily, not only the case manager, but also the rest of the team. And of course, just checking if the person is okay, what is she thinking about the treatment, if she's feeling fine with the treatment, the benefits from the treatment, the consequences that they can have if they do not do the treatment until the end. And I think the key is the relation. If we have a relation with the clients, they will do or they will easily complete the treatment. And of course, sometimes you need to give them conditions to do that. If they are coming every day to the mobile outreach program, so we will put the medication there. But if they're not, if they're at the shelter, okay, we will have a nurse team that will evaluate daily with them. Or if that's not an option, okay, we will talk with the diagnosis center and see the best option. So we are always trying to understand if it's okay and if we need to change the approach. I think that's the key for the success.
Can I add something?
Sure.
Because I think that what Carolina said is very, very important. But I want to add something. We had an experience, and there was a time when we had around 6% of abandoned TB treatment abandoned. And when we looked to the person to abandon treatment, they were most of them homelessness and users. So we needed to identify a strategy. At the time, there was an NGO, AFNES, that were working with peers and were building a group of peers that were knowing a little bit about infectious diseases. And they were our containers, that they were our, they were part of our team. And what we did was that we tried to identify persons that needed, of course, at first clinical point, but to understand, okay, what are the challenges to treatment? And you need to understand there are different challenges. So you may be director of a bank and there's some challenge to treatment. But this challenge is different from the person that does not have a roof or is at a user. So we need to identify the challenges to treatment and try to identify the strategies to overcome this challenge. So whenever we found some drug users, some homelessness, we try to understand, okay, how do you want to do the treatment? We explain the treatment, how do you want to do the treatment, where do you want to do the treatment? And treatment was done wherever and when you want it. So we worked with the NGOs and they helped us to do the treatment. And if they wanted to enter some reduction strategy, risk reduction strategy, okay, the door was open, so they could if they wanted, they just could enter the program. And one thing that was very, very important is, why do patients abandon treatment? Why? And they abandon treatment because they don't understand they are sick. Because of it's not important for them. They don't feel anything, that they don't value the symptoms, so they don't understand why they need to take medication that has adverse events. So they don't accept the adverse events. So what we found important was that, of course, our role is very important, but we are medical doctors. You know, we live and work in a very clean environment, and they look at us like, you know, like we are up there. So we needed someone from the field, that peer, that would help us and try to reach them and try to understand, to help them understand the importance of doing treatment, the importance of adverse events, because we have rifampicin, and rifampicin, with the rifampins, will decrease the dose of the drugs they use, the methadone. So they would not want it. So the peers were really, really important, and the NGOs in the street to understand, okay, what the person really needs, what kind of economic, psychological support, but also social support. And the peers were very helpful identifying the person that would drop off treatment and help the person to go back to treatment, advise about adverse events, advise about everything. So if the team in the field, knowing exactly what the difficulties are, because sometimes here, when I'm a medical doctor, you know, and I am not in the field, I'm not seeing the person in the field, I'm not seeing it. The person in my office, the person looks different. Okay, I'm not seeing the person in the environment, so I don't feel all the challenges, I don't feel all difficulties is facing in the field. And these teams and the peers are essential to be sure that these persons that will abandon treatment, because mostly of adverse events, stick in the treatment. And I must tell you that we had 6%. The higher percentage were drug users and homelessness, and now we have less than 1%, 0.6 or 7% abandoned. So this was published, and so this shows the importance of this work in streets. You know, shoulder with shoulder. It's really, really important, because they see the environment, they see the person, but not the person within everything that goes around.
Thank you so much, Raquel. May I just ask, is this the way you work in your hospital, in your unit, in collaboration with all these stakeholders? Is it?
Yes. One thing that we did from the beginning, I quickly understood, and I'm quite old now, I'm 57, so I'm working for more than 30 years, and I quickly understood I could not work alone. Okay, I could not work from my office. In my office, you know, I'm in a box. I'm not seeing the person in the environment. I'm not seeing the whole situation. So from the beginning, we work together. We work with the NGOs, with the family physician, with everyone. So with different stakeholders. So the important is to identify the different stakeholders, and we need to work together. And it's important for the homelessness, but it's also important for the persons that live that are incarcerated. It's also important for different migrants. We need for migrants, documented and undocumented persons, that sometimes enter the group of homelessness, but sometimes they do not, and they are non-documented. And we need to work with peers. Sometimes we face a very common challenge, that this language, we cannot communicate with them, and we need a peer from the group to help us to communicate, to make ourselves understandable. So it's very, very important to identify the different stakeholders, identify our vulnerable groups, because each one of us in the country and the world will have different vulnerable groups. Okay, can be drug users, can be homelessness, can be migrants, can be minors, because minors also have a higher risk of TB, and the stakeholders are different. So we need to identify our vulnerable groups, the stakeholders we need to work with, and we definitely need to work in a multidimensional way.
Thank you. Also, for any publications that you mentioned, we would really love to receive them and share them in our networks.
They are available on WHO. They were identified as WHO good practices, the one with drug users, the one in the jail. So they are published in WHO best practices, but I can share with you.
Yeah, I think we will also look for them. Thank you for mentioning that. We are closely getting towards the end of the webinar. I would like to check one more time if there is anything else from our participants today that they would like to raise or to ask. Or Carolina, if you have anything to add at this moment. While people are reconsidering if they want to ask one last question, this is the last chance. I will take this opportunity to do a bit of promotion for the third and last webinar that we are preparing, which is going to be on mental health and homelessness. A lot has been also mentioned today about the connection with mental health and mental well-being, and we will address this topic on the 21st of November. The link is in the chat for those of you who would like to join us. And yes, I think I don't see any signals that anybody wants to add anything, unless there is something from our speakers to add at this moment. I would like to thank you very much for joining and for sharing these insightful presentations. And we do take away the points that you highlighted so well, Raquel, and that came out through your presentation, Carolina, and from Al's stories as well, that we need to go to the field, to meet people where they are, and to keep people at the heart of our work, to think from a social perspective as well as medical. And we are always happy to have doctors engage with us in the homeless sector as well. We see no other way of doing this except for in collaboration and learning from each other. And yeah, great to hear so many inspiring presentations today. Thank you so much.
Thank you. It's a pleasure.
Thank you.
Thank you.
Have a nice day, everyone, and hope to see you in November.
Bye now.
Bye.
Bye. Thank you.